Good evening, everyone. So sorry we're just a little bit late getting on this evening, but we are so excited you guys are here. My name is Christy Mershon. I am the marketing manager here at RBA. I'd like to introduce to you Dr. Shapiro. He's going to be presenting this evening. Dr. Shapiro joined RBA in 1995 and currently serves as our medical director. He is a native of Miami, Florida, and went to medical school locally here at Emory University. It was during his training that he became interested in reproductive medicine by doing a research project with RBA back in 1987. Dr. Shapiro is board certified in both OBGYN and reproductive endocrinology and fertility. And we are very excited to have him this evening to discuss PCOS, which we all know it is PCOS Awareness Month. He will present this very informative webinar, and if any time during this presentation you guys have any questions, please feel free to put those in the chat box as we will be monitoring this. And we want to make sure that it is not only informative, but also interactive. So Dr. Shapiro, thank you again for being here tonight. I'm going to go ahead and turn the floor over to you.
Thank you, Christy. Hi, everybody. Sorry about the technical problem. I had the wrong link. It put me in an endless loop. So now we've got to get to the presentation. There we go. So welcome. We're going to talk about the polycystic ovary syndrome this evening. And the topics are, what is PCOS? What causes it? How do we treat it? Who are we? We are the oldest continuously operating reproductive endocrine clinic in the United States, actually. Private reproductive endocrine clinic in the U.S. We're part of the Prelude and Inception Network now, which includes practices across the United States, as well as the My Egg Bank and Haven Cryo and several other fertility practices that support the general business. We're very happy to have all of you here. Our goal is to help people have families as efficiently as possible. Nothing gives us greater pleasure and makes us feel like we've done our jobs well. So that's me. Turkey neck's coming. That's what 60 does to you. This is the rest of the staff. We have, fortunately now we're multi-generational. We have a young crew of physicians who are coming in and really influencing how we practice. We have our own urologist, that's Dr. Witt, and Dr. Naj has been our senior embryologist for the last 20 years. And once upon a time, he was on the list of 100 scientific authors you had to read before you die. Quite a dude. All right, and this is where you can find us. We're in Sandy Springs, in Midtown at the Piedmont campus. We have a Marietta office near Kennestone Hospital, and we're now in Braselton, and we've had an office close to Northside Hospital, Forsyth, for a while too, and coming. So what is polycystic ovary syndrome? Well, the name itself is a terrible name. It has absolutely nothing to do with ovarian cysts. It was named in 1937 by Dr. Stein and Leventhal, who were practicing at the Michael Reese Hospital on the south side of Chicago. At that time, some of you may know there was a depression going on, and the sociology of how we live is very different. Average age of marriage was about 18. And so if a young woman was in a depression-era family and was not marriage material for the day and age because she was not ovulating and may have had some cosmetic challenges with hair growth in the wrong places, hair loss on the top, and obesity she could not control, even in a time of depression, that became a bit of a sociologic problem. And so a lot of these young women were brought to Dr. Stein and Leventhal, who were gynecologists at the time. There were no x-rays, there were no hormonal assays. And so what they did is they operated on these young women thinking that they could find a source for their lack of ovulation in their ovaries. And it turned out that wasn't exactly right, but they did a procedure called a wedge resection where they took a chunk of the ovary out. And when they did that, lo and behold, those women started ovulating. And in the original paper of the 7 women who had wedge resection, 6 got pregnant. Several of the women were married, and others became married after the surgery. So, pardon me. So they got a lot of attention because of that paper, and they called it the polycystic ovary syndrome because when they looked at the ovaries of these young women, instead of them being kind of lumpy, bumpy, and a little bit discolored from kind of an opal colored white with a little bit of yellow streaking, there's a lot of lumpy, bumpy, and yellow streaking and areas of discoloration in a mature ovary. A polycystic ovary is actually about the same size, but it's perfectly smooth. It looks like a 3-minute hard-boiled egg. And right under the surface of that very smooth egg, so to speak, you can see these teeny little areas of fluid collection. Those are the cysts. That's all a cyst is an area with fluid in it. And Stein and Leventhal didn't know this, but those were egg sacs. And they also didn't know the most important part of it, which I'll explain in a moment, is those egg sacs are being inappropriately stimulated by the hormone LH, luteinizing hormone, which I think it's Latin, means yellowing hormone. And the reason that the ancients called it that was because they knew that when this hormone went up, the part of the ovary that ovulated turned yellow. And the reason it turned yellow was because cholesterol is yellow, and that's what's sequestering in the area of ovulation, because all the hormones, the steroid hormones, come from cholesterol. And you can't make progesterone if you don't put cholesterol into the ovary first. And so that's how the hormone got its name. So they didn't understand what was going on, but they knew that the surgery worked. And now here's why the surgery worked. And actually, let me move on just a little bit. Why did the surgery work? The surgery worked because all of those teeny little egg sacs are making the wrong hormone. They're making a male hormone called androstenedione. Androstenedione is actually the most predominant ovary hormone in the ovary. And it's made by the action of the hormone LH. So when LH, luteinizing hormone, comes down and touches the ovary, and the LH is there all the time in low amounts in the normal cycle, it's enough to tell the ovary to make this male hormone. Well, why is this so important? You need the male hormone to make another male hormone called testosterone. And it's the testosterone that is the precursor molecule and the source for all the estrogen of ovulation. All estrogens come from androgens, male hormones. And Stein and Leventhal didn't know that either. So lo and behold, what happens in normal ovulation? Well, if you're not already, let's assume you've already gone through puberty and the previous ovulation didn't work. The FSH and the LH are low. Those are the hormones that are going to call forth an egg. And why are they low? Because the previous cycle, they're waiting to find out, did a pregnancy occur? Do we need another egg? Well, when the estrogen starts falling from the previous cycle, the FSH knows it's got to go up. And the brain tells the pituitary, FSH go up. The FSH goes up and it goes down to the ovaries, and it says to both ovaries, hey, I need an egg. The ovaries have lots of candidate eggs, and the younger the woman, the more eggs that stand up and say, "Who pick me?" The FSH then decides, within a complicated hormonal negotiation, which one of the candidates will get to ovulate. The rest, they don't get to compete again. They get the whack. Actually, they're gone. But the one that gets to ovulate, she's in good shape. Well, what happens is the FSH is going up. The lead egg starts making estrogen faster than all the others, because FSH also tells the egg sacs to start making a little bit of estrogen. And how does that happen? The FSH says make the enzyme that converts the male hormone to the estrogen. As the estrogen goes up, the FSH goes down. But as the estrogen keeps going up, which it will do, even if all the other eggs die off, the lead egg is basically saying, hey, I'm here, to the brain. And the brain sees all the estrogen pouring out of that one follicle and says, yeah, we got to ovulate. And it lets loose a surge of LH, the luteinizing hormone, goes down to the ovary, says, let's ovulate. The ovary says, you got it. There she is. Eggs ready. The LH makes the progesterone production begin, which actually pushes the LH down. It also tells the follicle wall to dissolve so the egg can get out. And it tells the egg to ripen, which is the most important thing, so that it can fertilize normally. And out comes the egg, and hopefully there's sperm in the neighborhood and pregnancy and blah, blah, blah. We're not going to talk about that part. So what happens in the PCO? Not that. PCO starts as most likely as a lesion in the insulin receptor. What is that? That is the protein in your muscle cells that helps sugar get out of circulation after you eat a meal. Very, very, very important structure, the insulin receptor, because without it, we'd all be diabetic. But the insulin receptor can be modified, and there are genes that will make the insulin receptor not work so well. And that's on purpose. Why? Because when you eat a meal and you absorb the sugar and the insulin goes up, the insulin has multiple effects. At higher level, the insulin will tell your liver to take all the sugar you're absorbing and convert it to fat to protect against the famine to come. Because remember, it wasn't so long ago we had relatives starving. Even in this country, until about 100 years ago, starvation was a regular occurrence. And so calories in human history have been hard to get. And so our genes are set up to help us store calories. Well, how's this related to the PCO? This is where it starts. Because when insulin gets that high, and it gets high because the receptor's been modified and it won't respond. So the pancreas is saying, hey, take the sugar out by making more insulin. And when insulin gets higher and higher and higher as a result, it tells the liver to take all the calories you're eating and turn them to fat. And then the insulin goes down to your ovary and it says, we don't have any energy to waste on a baby. We need to shut this down. And the insulin says to the ovaries, make more androstenedione, the male hormone. Now, the LH already tells the ovary to do that. And the ovary goes, okay, sure, why not? And it makes a lot of androstenedione in response to the excess insulin. The androstenedione eventually gets to be so high, the level, that it gets into circulation. And it goes to your fat, which is also more prominent because of the effect of the insulin. And the fat has the same enzyme that the ovary does to convert male hormone into estrogen. But the conversion, it's from androstenedione, but it's straight shots to estrogen. And when you take a straight shot from androstenedione to estrogen and bypass testosterone, you make a form of estrogen called estrone. And the estrone comes out of the fat, and it goes into circulation, and it goes to the brain. And when the brain sees estrogen, it can't tell the difference between estrone and the estrogen of ovulation, which is estradiol. And it says, oh, that must be from an egg. And if that brain thinks that estrogen signal is coming from an egg, it's going to shut FSH off because it already thinks it's got an egg. It doesn't need one. And if the estrogen signal is high enough for long enough, the brain thinks there's an egg trying to ovulate, and it releases the LH. And the LH goes down to the ovaries and says, let's ovulate. And the ovaries say, why are you here? I didn't call. And the LH says, yeah, you did. I got an estrogen signal. And the ovary says, not from me. And the LH says, you're confused. There's something wrong with you because I got a big old estrogen signal and you need to ovulate. And the ovary says, no, really, no egg. Send FSH, the other guy. And the LH says, look, you're so confused. I remember how we started puberty. I overdid a little and made you overproduce androstenedione to get the ball rolling. So guess what? Make more androstenedione. Well, there's already too much coming from the insulin, too. And so more androstenedione goes back out into the fat. It gets converted to the estrone, which goes to the brain, shuts the FSH off, and then keeps the LH on. And the LH goes back to the ovary and says, now? And the ovary says, nope. And the LH says, okay, make more androstenedione. And this thing keeps going and going and going. It's called the vicious cycle of the polycystic ovary syndrome. And what's the LH doing? It's driving all the eggs that thought they'd be getting an FSH signal to make androstenedione. And the fluid in those teeny little cysts is full of the male hormone because of the effect of the LH. And that's why when Stein and Leventhal took a chunk of the ovary out, it dropped the androstenedione level. And when that happened, the women stopped making estrogen and fat. And when that happened, the FSH went up. And when the FSH went up, it went down to those 18 and 19-year-old ovaries and says, now you can make an egg. And if they were married, they got pregnant. And Stein and Leventhal were hailed as geniuses and misnamed a very complicated endocrine problem that has nothing to do with the ovary. The ovary is the victim in this story, right? The instigator is insulin. And the criminal is the fact that we as human beings have existed in famine-wrought societies forever and ever. And so those of us who survived have these genes. That's why obesity is an out-of-control problem in this country, because too much sugar in the diet. The sugar raises the insulin. The insulin increases the amount of fat that we produce. And it's not just people who are heavy. Everybody fights this in our society because of what's in the diet. So that's what the PCO is. Now, how are we going to fix it? That's the bad news. Now there's plenty of good news. Okay? Got to find the button here. There we go. What are this? Well, let's talk about the symptoms. A little bit more bad news just to make the night icky. Weight gain even when you're dieting. That's one of the most common symptoms. Hair growth in all the wrong places for a woman based on our sociological norms, but still, it's a cosmetic issue, but still very distressing for a lot of people. It also causes, because of the effect of the male hormone, male pattern hair recession and thinning. And that can be cosmetically extremely distressing to women with the PCO. The PCO also changes your lipid profile, and so it increases the likelihood of heart disease later in life unless you account for it. And the way you account for it is by careful sugar control and by watching your cholesterol. And if necessary, you take a statin drug. Women with long-standing PCOS who rarely ovulate are also at increased risk for breast and endometrial cancer. Another piece of bad news, but that can be really, really mitigated very well by just being on the birth control pill. The longer a woman is on hormonal contraception, the lower her risk for ovarian or endometrial cancer. No impact on breast cancer, but significant decrease, not increase, but a drop in, especially in PCO patients who are at increased risk for these diseases. If you go on the pill, you lower the risk rather dramatically. And so it's really smart to be on the pill if you're not trying to get pregnant with PCO. So those are the big ones. So we talked about
Dr. Shapiro.
Yes.
Real quick, sorry, before you go on, we've got a question here.
Sure.
It says, what if you have been diagnosed with PCOS based on symptoms, but your fasting insulin levels are within normal range?
Okay, that's a great question. So you cannot use, perfect segue. Who is that? They get a $50 bonus check for asking the question exactly the right time. Joke. No, they don't. Sorry, that wasn't funny. Sorry, Christy, I put you in a bad spot, didn't I?
How about we give them a $250 voucher towards treatment when they attend the webinar?
John Carter will tell you what's behind door number 3. So, okay, so, got it. Now I've lost the question. What was it again?
It says, what if you have been diagnosed with PCOS based on symptoms?
Sorry, ding, ding, ding. Yes, some old brain, sorry. Okay, you can't use insulin. This is why the question's fantastic. You can't use insulin levels to make the diagnosis. You can't use anything except one of these 3. Irregular cycles, which means less than every 35 days. Normal menstrual interval is 23 to 35. When a gynecologist says, do you have regular or irregular cycles, we mean, is it between 23 and 35 days, and we don't care if it goes back and forth between 23 and 35. We just want to know 23 to 35. Women who report, though, if it goes from 28 to 31, some think that's irregular. That's totally normal. Even 23 to 35 is normal. But if it's longer than 35, it's not normal. And it is more likely to be associated with ovulatory failure. So that's one criteria, irregular cycles. That means fewer periods than you ought to have. Number 2, clinical evidence of hyperandrogenism. That means you have to have the acne or the hair growth or the hair thinning, or it wasn't in the original criteria. It's kind of slipping in now that if you have more than 2 androgen levels above normal level for a woman's range on separate occasions. Some people are accepting that as evidence, but that by itself traditionally was not in the criteria. And then the third criteria is the controversial one. It's an ultrasound to look at the ovaries. And if they have what's called the pearl sign or the necklace sign, all the little cysts right around the edge, then you have the diagnosis of PCOS. You do not have to be heavy. There is such a thing as lean PCO. The underlying mechanism might be slightly different in lean PCO, and those women are at lower risk for endometrial and ovarian cancer. But the net effect of the vicious cycle, that's actually the same. How they get into the vicious cycle is probably hormonally a little different. So the treatment for lean PCO might be slightly different. Insulin sensitizing agents like metformin probably don't work as well in people with lean PCO, but it works very well as partial therapy in women with classic PCO. So you can't use an insulin level. Most women with PCOS are at risk for type 2 diabetes, but they don't actually have it. And so their insulin responses are going to be close to normal, and their basal levels are going to be normal too. If you want to measure an insulin properly to know whether you're overshooting, you have to do something called a patch clamp, which is a 24-hour study where in one vein you put the glucose and in the other vein you measure the insulin response, and you do it at regular intervals over the course of 24 hours. That's what we used to do in the 1970s and 80s, and nobody does that anymore because it's crazy. You don't need to know that somebody has insulin resistance chemically. You can look at them and you can talk to them and you can learn just from a conversation whether they do or whether they don't. So that kind of testing doesn't really exist, and that's one of the main reasons why you can't use those criteria to diagnose PCO. Okay? Any other questions before we move on?
That was great insight. Thank you so much, Dr. Shapiro.
You're very welcome. So, this graph kind of shows what I described. I realized, Christine, I don't think it would be too difficult for me to open it. Is there a share screen thing that I can use? Christy?
Is there something else that you're wanting to share?
I realize I have a slide that shows the vicious cycle very nicely, but I know we can't load it here, but I guess I can't do a screen share. So never mind. It's okay.
No, unfortunately not.
That's fine. All right. Description will have to suffice. But this slide is basically a demonstration of the same idea. So now these are listed as contributing factors. These really aren't contributing factors. These are symptoms, the result of the PCOS. Okay. So the low-grade inflammation, actually, the ovary is mildly inflamed. The mechanism of that isn't very well understood because there's no infection, but there is an immune recruitment, and inflammatory cells populate the ovary in greater number when women have the PCO. And the connective tissue of the ovary gets a little thicker over time. The connective tissue is actually where the male hormone comes from. So that actually kind of makes sense. But why it would be inflamed, that's still a little bit of a mystery. The obesity, I think, for women who are heavy with the PCO, I think we explained how that happens. It's the dirty deed done to you by your own insulin. Irregular periods, that's because of the vicious cycle. There are women who will ovulate from time to time with the PCO. Why that happens, why women break through and get into normal pattern ovulation isn't very well understood. But this varies quite a bit, and it probably has to do with the quality of the diet over time. Maybe a 2-week period after vacation, things are worse. A month where you did keto and Atkins or whatever, and it got better. Who knows? There are all kinds of influences like that that are hard to gauge. The acne, that's from the male hormone androstenedione. So is the body hair, so is the female pattern hair thinning. And the weight changes is weight gain, even with what most people would consider to be calorie restriction. On that point, well, actually, we're going to get to that in treatment. So lifestyle modification. So I'm a big fan of looking at this as the patient being kind of the victim of their own endocrinology. So rather than a willpower or a look what happened to that person kind of thing. Because if you disempower somebody by blaming them, they're not going to be motivated to help themselves, right? But if you show them the mechanism and you explain how they can fight back, then maybe they'll be motivated. So how do you fight back? Well, calorie restriction is obviously important, but you could live on an 1,800 calorie a day diet and feel full if you eat the right foods. The trick is to literally take all the white food out: potato, pasta, rice, bread, the good stuff, desserts, white sugar, processed anything, all fast foods, every soda. The diet soda is okay maybe every now and then, but no fruit juice, no sugar in the coffee. This is serious, right? If you're really serious, you got to fight by taking away the sugar. It is a modern phenomenon that there is sugar in our diet. Until about 150 years ago, sugar was a rare spice to be had, and it was a delicacy that only rich people could afford. And we didn't have as much obesity in this country. So sugar's the killer. Gotta get rid of the sugar. The other thing you can do is eat as much fresh fruit and vegetables as possible. Now, yeah, fruit are carbs. There's no question about it. And yes, if you ate 10,000 calories in grapes, that probably wouldn't be very good. And you'd probably be in the bathroom all night too. But there's a limit to it. But obviously till you feel full. But fresh anything is a big thumbs up. Fried food generally frowned upon because it's often breaded, or it's a potato, right? So go easy on the fried. Eggs, fine. Bacon, fine. But you got to count the calories and keep it around 1,800 for most people. If you add a little bit of daily exercise, we're not talking about Orange Theory. We're talking about a walk in the hood. 30 minutes, doesn't have to be fast, just 30 minutes of moving. You've done yourself a favor. Some women should be on metformin, okay? So that's the medication, all right? Metformin is the mainstay for classic PCO because what it does is it tells the liver, hey, stop making sugar too. We can't do anything about you making the fat, but don't make our lives worse by making sugar in addition to all this other stuff you're making. And when the metformin shuts down liver production of the sugar, the unified value of sugar in circulation goes down quite a bit. And it has to be made up by pulling from sugar sources or, if you can't get sugar, from fat. And so over time, by approaching the problem that way, you pull from fat stores and you begin to get the endocrinology a little bit better. It lists here phytoestrogen supplements. Yes, some may be, but there's none I'm going to endorse because those things aren't regulated and you really don't know what's in them. Things that claim to be pro-fertility usually are phytoestrogens, meaning they actually have estrogenic effects that you don't need and might be harmful in an attempt at ovulating. And so I wouldn't take them. Not because they're harmful in general, but because they might be running counter-purpose to what you're trying to accomplish. There's a newer approach that's emerging. These are the GLP-1 agonist drugs, which have the catchy tunes, you know, for like bum, 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 bum. That one is one of those drugs. And the one to whoa, 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 it's magic from the 1970s. Yeah, that one's one of those drugs too. They're diabetes drugs. And those drugs actually cause significant weight loss. And miraculously, a secondary effect in women with the PCO, not only does it allow for rapid weight loss, these drugs also seem to promote normal endocrinology out of the fat. And as a result, ovulation is much more likely to occur naturally. The problem with these drugs is that they're none of them safe in pregnancy. So if you're taking them, you have to monitor for pregnancy before every single visit for a shot. And there's usually weekly injections. And if you have a positive test, you can't take the drug, which for people who've lost weight on it, and this is anecdotal, I haven't written for these yet, but I've heard patients who've come to me who've had 35 and 50-pound weight loss by doing a round of one of those two drugs. And it caught me by surprise. I did a little reading not too long ago on this, and yeah, there you go. This might be a new approach. It needs a little bit more study before we can jump it. But again, it's not safe in pregnancy, so it's got to be rolled out safely when the time comes. Maybe soon, hopefully soon. And then surgery. This is the wedge resection. Now we make it fancier by turning on the laser and burning the little cysts with the laser. Yeah, don't do that. That's not a time limited. That is a procedure limited approach because, yeah, it might make the woman ovulate, but most women go back to not ovulating over time after these procedures. And so if you want 3 kids, you have to have 3 wedge resections. How much ovary would be left? You know, there are other things ovaries do besides produce eggs that are beneficial for a woman in her reproductive years for her general health. And so damaging them on purpose, not my favorite idea. But again, that was the historical way of treating this condition. The other medications that can be used to treat the PCO are for ovulation induction. And those drugs will do, let me go back. Those drugs are letrozole. These are the generic names. Letrozole, I'll explain what that does in a moment. Clomiphene citrate, its brand name is Clomid. It's been off-label for years, so everybody still calls it Clomid. Injectable follicle-stimulating hormone, human chorionic gonadotropin, which is the hormone of pregnancy, but mimics the hormone LH. There is no LH product on the market, interestingly enough. That's a long story we don't have time for, but HCG mimics LH, and so you can use HCG instead of LH. And what did I leave out? Oh, and the agonists and the antagonists, which are drugs like Leuprolide, which in the US is Lupron, or the 2 antagonists, Cetarelix and Ganirelix. Those drugs have the net effect of shutting LH off, and they're often used for ovulation induction, and they're very effective in preventing premature ovulation in women undergoing stimulation for IVF. So how does letrozole work? Letrozole inhibits the enzyme that converts male hormone to estrogen. So when you take these drugs, the estrogen levels fall, even if the ability to make it is still there. What happens when estrogen falls? The brain says, where's my egg? And it says, make me an egg by secreting FSH, follicle stimulating hormone. So the net effect of anastrozole or letrozole is make FSH go up. Clomiphene is also an estrogen antagonist, but in the brain directly. It doesn't work in the periphery like letrozole does. It only works in the brain. It says the same thing. There's no estrogen here. And the brain says, are you sure? And the clomid says, oh yeah, no estrogen. And the response then is for FSH to go up, same thing. You can also inject FSH. There are 2 recombinant products, which means they're synthetically engineered human FSH, genetically engineered rat cancer cells, if you must know the truth, were retrofitted with human DNA, and they make recombinant FSH in big fermentation vats in Switzerland and in Puerto Rico. And this is where all the fertility drug pretty much is coming from. There are also FSH products that are urine-derived. There is one on the market in the US. That product also has low-dose HCG in it, which acts like LH. And that combination is called human menopausal gonadotropin. Why? Because it comes from the urine of menopausal women. The original source were nuns in Switzerland. I am not making that up. The Bertarelli Foundation and Organon before them collected the urine of either pregnant horses or menopausal women and derived these hormones from those sources. And for many years, that's what the fertility drugs were. There is one that is still a urinary product. There are some advantages to the urinary products, but not much. But if you want to get LH, one of the ways you get it is by using the HMG product. And so that's pretty much what we use. HCG in large amount is used to mimic the LH surge, and that causes ovulation. And then Lupron, Leuprolide, Ganirelix, and Cetarelix, they block the effect of the master hormone in the brain that tells the pituitary to make LH. That can be used in a number of ways. If you want to shut down LH in someone with PCO, that's a historical way of doing it. We don't do it that way so much anymore, but that is a perfectly acceptable way to do it, an expensive way to do it. One of the main reasons it's not done that way anymore. But that's one application. The other application is, as I said, in ovarian stimulation, where we don't want the eggs that we're producing to ovulate prematurely. And so if you're on one of these 3 drugs, you won't. It's still a 1% chance, but it's a rare event. So I think that's it for everything. How do you start with us? Well, go register. Get yourself on the schedule for one of the 7 REIs. Our business office will help you figure out if you have insurance. Don't be surprised if you do. People who have employer-sponsored insurance, especially if they work for a larger company, might have some benefit. Some people will know that they've got it, and some people will know for sure they don't. But always check with our business office. They can check for you. And then if you can get your records in advance, there's a handful of things we really, really like to see right up front if it's already been done. And those are the X-ray called the hysterosalpingogram, the dye test of the uterus and fallopian tubes, the AMH test, anti-Mullerian hormone level. It will be high in most patients with the PCO, but if someone tells you you've got a high AMH, that means you have PCO, that's not right. There are lots of women who do not have PCO who have very high AMHs. Lucky them, right? Just means a lot of eggs. So we like to see the AMH, anti-Mullerian hormone level. If your husband's had a semen analysis, yes, we'd like to see the results of that. And a lot of OBGYNs now are doing what's called carrier screening, which is when their patients are coming in, they're doing genetic testing to see what recessive diseases their patient might carry. Then if you find which diseases you carry, and almost all of us carry something. So if you, especially with the panels, there are 500 diseases on them. So what's going to happen when you test? You're going to come back positive for something. Not a problem so long as your partner doesn't match up. So you can both carry several diseases so long as they're not the same diseases. Your babies would not be at increased risk. And so that's becoming a popular test to do in the OBG's office. The ones that haven't caught on to that yet, we'll get to it. We order it. There's a nice package deal. It's not expensive to do, actually, and very much worth it. It's for safety for your kids, and so we strongly advise it. And that's what we'd like to see. Any surgery records, any records of prior fertility treatments, also very valuable. So once you've done that, come on in, or telemedicine, which is actually becoming my new favorite way of doing this. Make the appointment. We'll go over how things are done. We'll set you up with our nursing staff to get the legwork done. And then the physicians oversee their patients and the management of their treatment cycles. And when big decisions need to be made, we meet, we talk, either in person or online, whichever is more convenient for you. And again, if you have any questions now, please signal us. I'll be happy to answer them. And thank you very much for taking the time.
Thank you so much for that presentation, Dr. Shapiro. That was very interesting. We do have just a couple audience questions here that we would like to get your insights on. One of them is, after all the drugs to stimulate ovulation and a woman gets pregnant, what are the hormones controlled? How are these hormones controlled during pregnancy?
The hormones of the PCO, they're not. Okay, so one of the consequences of pregnancy is that the HCG level is chronically elevated. It's always there. HCG will tell the woman's ovary to make male hormone. That's a natural consequence of pregnancy. The endocrinology of this is far more complicated than we have time to explain, but the uterus actually has receptor for male hormone. And the variation in the amount of androgen that mom produces and allows her fetus to be exposed to will also have influence on her fetus to some degree. So there was a paper from the 1990s that tried to show that PCO women were at greater risk for hyperandrogenization of their female babies especially. And that turned out not to be true. It turned out that the actual testosterone level or the androstenedione level did not correlate to androgenization of those babies at all. And androgenization in the PCO group occurred at no higher rate than in the normal population. They didn't understand why then. Now we understand the hormonal capture effect of the uterus and how that varies. And that's not a product of what the level is in the mom's circulation. It's a function of how her uterus literally fishnets the male hormone before it gets to her fetus. So hair growth might progress, but the estrogen level of pregnancy is also sky high. And one of the benefits of sky high estrogens is you generate a protein called sex hormone binding globulin, which is basically like the cheesecloth you go over the countertop with when you want to pick up all the stuff you don't want free and loose, from the crumbs from the bread you're not supposed to eat, right? Think of the androgen, all steroid hormones, but especially androstenedione and testosterone. Think of them as the crumbs from the bread. And the sex hormone binding globulin is the cheesecloth that picks it all up so that it can't get to the tissue and cause the androgen effect. So the high estrogens of pregnancy are also highly protective through that mechanism. But it's a great question, and it's kind of baffled us for years why there aren't more androgenic consequences to babies or the moms during pregnancy. There is a side note to that. There is a subset of women who have PCO-like presentation who actually have a disorder called congenital adrenal hyperplasia. Those patients are treated differently in pregnancy. When they're properly identified, they're actually on like corticosteroids to suppress the androgen production out of their adrenal glands, not out of their ovaries. And so, but the same capture mechanism exists in those patients, but still there's much more likelihood of androgenization in a woman who has congenital adrenal hyperplasia. So great question. Ooh, interesting question. All right, next one.
Yes, awesome. Thank you, Dr. Shapiro. The next question here is, do you require that a patient has tried to conceive for 12 months prior to making a new patient appointment?
Not really. A lot of people already know they've got an issue, either because they were in an infertile relationship before, or because they know they don't get a period regularly, or because their husband had a vasectomy because he had 2 kids already. A lot of people know. And so waiting 12 months if you already know that there's an issue, yeah, don't do that. If you're perfectly healthy and ovulate regularly and your husband's perfectly healthy and has normal sexual function, then yeah, if you're young, you might wait a year. But young means like under 33. 33 to 35, 36, okay, maybe 9 months, maybe. Once you get over 35, though, and by the way, 35 is not when women pickle. That is a sociologic urban myth. Eggs are lost from the beginning, right? You don't suddenly fall off a cliff at 35. Sadly, some people start going down an egg supply way earlier than that. There are patients. And some have plenty of eggs right up till 41, 42 and had fertility like it was nothing. Right. So 35 is not really, it's from politics of abortion in the 1970s, has nothing to do with real physiology. But if you are over 35 and you want 3 kids, well, that's going to be a little tough because eggs do run out and natural fertility is pretty well gone by 44. So for someone who's starting a family at 35 or 36 who wants more than 1 or 2, some of those women might think about banking embryos so that they have healthy, or the availability of healthy embryos to make babies well into their 40s if they want, so that they don't have to feel the pressure of their physiology to finish a family in a crunched up time. Or get married at 22 and, be a Duggar. There are choices, right? But
right,
we're here to help people do the former, not the latter. Anyway, go ahead. Sorry.
So, no, I was just going to say a couple more questions here. How do you distinguish a patient has congenital adrenal hyperplasia versus PCOS?
That's a great question too. Okay, so there's a test called the 17-hydroxyprogesterone. Anybody who is presenting with PCO-like symptoms must have a 17-hydroxyprogesterone drawn with all the other labs that the doctor's probably going to order. Why? Because if you have congenital adrenal hyperplasia, the 17-hydroxyprogesterone is going to be elevated. In the PCO, it is going to be normal. And there are two types of congenital adrenal hyperplasia. There's classic, which nobody misses because it's evident in the nursery, right? It's the late onset form, the virilizing late onset form, the kind where there's something maybe a little endocrine off it's mostly noticed in girls because they tend to have early puberty. They tend to have been heavier as kids, even though they weren't compulsive eaters. They didn't have any other eating issues. They gained weight by the mechanism described before. But they got into the vicious cycle because of the over secretion of androgen from their adrenal glands, not from their ovaries. That's how it started in those patients. They're treated with corticosteroids. You suppress the adrenal androgens. Women with congenital adrenal hyperplasia, when they're going through IVF or any other ovarian stimulation, they also go on corticosteroids to suppress their androgen response so that it doesn't get too high during the stimulation. That's how you do it.
Excellent. Thank you, Dr. Shapiro. Next question here. Is it possible after IVF and having PCOS that you cannot get pregnant?
You mean become infertile from having IVF? Is that the question?
I think it's more, is it still possible after doing IVF and having PCOS that you may not get pregnant?
Yes, it's entirely possible. Unfortunately, Mother Nature does not know that we have individual hearts, minds, and feelings. She is a very cold-hearted you-know-what. And she did not know that we would have feelings about all of this. You got to remember how we lived not that long ago. Our expectations of how things are going to go now are based on modern work habits and sociology. Our grandmothers were all mothers by the time they were 22 or 23. And most of them had, 3 or 4 kids. And our great-grandmothers probably had 5 and 6 kids. And they probably had some kids die in infancy, too. It was a very different world. It's hard to imagine. But I got off track, didn't I? But yes, back to the main question. If you have PCO, the main thing about whether or not you're going to be able to get pregnant or not after IVF, meaning you did IVF and it didn't work, and you wonder, are you going to remain infertile no matter what? No. It is still entirely possible if you have open fallopian tubes and a husband who has sperm that you could ovulate spontaneously and get pregnant on your own, and it does happen all the time. An IVF failure in the PCO is not that uncommon, though PCO patients tend to make tons of eggs, and so they tend to be the ones who get pregnant most easily. But there are subsets of PCO patients. It's not really all just one form of disorder. It's multiple little disorders under one heading and different flavors of the PCO. There might be egg and embryo quality problems. There might. Some of those women might not be able to produce healthy eggs. That's possible. But the younger the patient, the more likely that is to be untrue. For somebody under 35, it's real likely the eggs are okay. They're not maybe as plentiful at 35 as they were at 25, but they're okay. They're better than okay, right? It's 39, 40, 41, 42, where we're not being truthful if we say, oh, that's easy. Even with a high AMH, you'd make a lot of eggs, and that makes it much more likely it'll work. But at like 41 or 42, the genetics of the egg become the enemy because Mother Nature also set the system up so that the good eggs would be destroyed first. Remember the competition? Yeah, that's only one way that eggs get the whack. There's this thing called ovarian atresia that comes in waves every few months. And literally, it's like the lemmings being pushed off the cliff. And there's nothing anybody can do to stop it. It's the thing that if anyone could ever figure out how to preserve eggs without taking them out of the ovary to stop ovarian atresia, that's $1 billion product. I will share your yacht with you for suggesting the idea. But it's really that elusive. There are companies that have tried. There are scientists who have claimed to have found the Holy Grail in that department. All a lot of hot air and a bunch of scientific brouhaha that wasn't true, and sad, because with modern thinking, this is the one unfair deal women get in the equation. Limited egg supply.
And I think you just touched on this, but we do have another question along the same lines. Can I get pregnant having PCOS?
Absolutely. So most PCO patients, especially if they're under 35, will get pregnant with minimally aggressive ovulation induction. That has been true since in the 55 years since Clomid was approved in 1967. That has been true. There is so much data on this that is absolutely clear. If your tubes are fine and your husband's fine and you ovulate readily to either Clomid or letrozole, most patients will get pregnant in their OBGYN's office from he or she just giving the drug, for true and for real. The people who don't get pregnant easily tend to be the ones who don't ovulate to minimal provocation ovulation induction. They need more. They need the shots. The minute you need the shots, it starts to get a little complicated. And the minute it gets complicated, the OBGYNs can't do it. That's what we do. And so, but is it easy to help a PCO patient achieve pregnancy? Yes, but there is a little bit of a double bind here. The double bind is that the easier way with the shots, insemination, is where John and Kate plus 8 came from. And that's really hard to stop with that therapy. And it's going to happen from time to time. And now we live in a world where Roe is gone, and where if somebody had quints, that's an extraordinarily dangerous pregnancy. And I understand people don't like talking about abortion very much, but it medically is just, it's impossible to look someone in the eye and say, yeah, carry your quints. It's too dangerous. But you can carry a twin safely after reducing. But, that's the danger with IUI therapy and the PCO. And that was a huge problem in the 1970s and even into the 80s. Then IVF came along. The bad thing about IVF is it's expensive. And so if you don't have insurance in the US, it's expensive. But that works great because you get the eggs out, usually get a ton of them, usually get tons of nice looking embryos. Most of them in the younger patients, the majority are going to be genetically normal. And that's a recipe for a nice big family. But it's expensive. You can control multiple birth in the PCO with IVF because we only put one embryo in at a time. And there's another kind of nasty condition called ovarian hyperstimulation syndrome. It's preventable in IVF. If you complete an IUI cycle, it is not preventable. And so even though IUI is much less expensive, it's more dangerous because of the multiple birth issue and because of the hyperstimulation issue. It has to be done very, very safely, and it's hard to do that way. IVF, bad thing, expensive, but highly effective. So most young PCO patients, it doesn't take more than one IVF cycle to get all the embryos you need. Even up to age 38, that's probably true for most.
Awesome. Thank you, Dr. Shapiro. We're almost out of time, but I'll go ahead and leave the Q&A box open just in case anyone has any other questions. Just wanted to say, Dr. Shapiro, thank you so much again for your time tonight. We really appreciate it. And thank you to all of our attendees for being here and taking your time out of your evening for this special webinar. We will send you a voucher for $250 off of a treatment, so be on the lookout for that. It will arrive via email. And then, of course, please visit our calendar of events as we have several educational seminars and webinars throughout the year. So definitely take a peek at that and see if there's anything else you'd like to attend. And I think one last question here, it's the price for IVF treatment.
Varies. Okay, so no two patients are exactly alike. For some people, the single, other than the egg retrieval procedure and the whole thing, the single biggest block of expense is the drugs. For other people, the drug expense is a lot lower. So the overall price without genetically screening embryos is anywhere from about $18,000, including the drugs, up to as much as $23,000, including the drugs. If you then add in the genetic screening, it depends how many embryos you get, but figure about 2,500 to 3,000 for the genetic screening of all the embryos that are available. You just tack that on to the overall cost. Embryo transfers, I don't know the exact price right now, but I think it's somewhere near $4,500 for a frozen embryo transfer. There are packages available. We're still doing bundle, Christy? Right. And there are ways that you can bundle up your packages. I don't know how they work. That's a business office thing. I'll tell you the wrong thing, and someone from the business office will come down and yell at me for saying the wrong thing again. So I think you just need to talk to the business office. But there are ways to group up the services so you have a flat fee and there's no surprises. That might be a good option for a lot of people.
Yes. And after Dr. Shapiro or one of your fertility doctors prescribes your protocol and you know what your treatment plan is going to look like, you will meet with our business office so you have a better idea of what the cost will be and the bundle packages if you want that, as Dr. Shapiro mentioned.
Okay.
Anything else? I think we're just about out of time, but thank you again for your time tonight, Dr. Shapiro. We appreciate this great webinar.
And I'm sorry about the link problem at the beginning. Thank you, everybody, for your patience. Have a great night.
No worries. Thank you.
Thanks. Bye.